Hello, Peter.
Hi, Dr. Salzberg.
Nice to see you again.
My pleasure.
We're 1 month after surgery now.
Yes.
So tell us, how did you end up having surgery by myself here in Zurich? What was your disease course? What happened to you? Because you're young and fit.
I am young and fit. I was young and fit, so I'm very pleased about
You
that.
are young and fit again.
Indeed.
Are you still young and fit?
Indeed. Through a routine checkup, there was a whistling heard when they listened to my heart.
Mm-hmm.
And out of precaution, I felt, let's not take it easy. I had sports injuries before, and signals shouldn't be ignored. So I, through my network, was lucky enough to find you and contact you. And lucky for us, at the same time, unfortunate, I'd rather been healthy, we diagnosed severe aortic valve insufficiency. And then we went about it very fast and quick. As pleased as I was back then that we were able to time it a little bit and get me in shape.
Mm-hmm.
I think I benefit from it now.
Yeah.
A month in, and I can already run again. I can cycle on the stationary bike very well again.
So let's go back a couple of steps. So you had by chance a routine physical examination.
Yeah.
And then a young cardiologist did an ultrasound on you and saw that your valve, your aortic valve, which only has 2 leaflets, so you were born with this defect, wasn't functioning properly.
Correct.
So she told you to seek the advice of a cardiologist.
Yeah.
And that's when you contacted me, even though I'm not a cardiologist, I'm a cardiac surgeon. Together with our cardiology partner, we did a complete workup. So we did the echo through the chest, we did the transesophageal echo, we did an MRI, we did a stress test. So we finally assessed that your valve was incompetent, didn't work well, and your ventricle was already enlarged. So we had to do surgery rather earlier than late.
Yeah.
So you underwent aortic valve replacement through a mini sternotomy, and you stayed in the hospital for 1 week?
8 days.
8 days.
So more or less a week,
Yeah. And after that you were in rehab for 2 weeks.
Correct. Cardiology Rehabilitation Center in Davos, obviously linked through data exchange, which was very important to me as a patient with you, to have that dialogue.
So I have a much more important issue I'd like to discuss with you on the camera.
Yeah.
You decided to have a biological prosthesis.
Yeah.
I mean, you are, how old are you?
44.
You're 44. You're very young.
Yeah.
You're physically active. And so I basically told you require a mechanical valve, which also means that you need lifelong anticoagulation with Coumadin.
Yeah.
The advantage being the valve lasts forever. But I also offered you the possibility of a biological prosthesis, which may not last forever, but doesn't require any medication.
Yeah.
So what was your thought process there? Why did you in the end decide you wanted a biological valve and not a mechanical valve?
There are 2 components. So one, I think, what was incredibly important to me, that is, I feel more comfortable if I can objectively compare data. And I think the way you explained all the options, it was very clear to me all options work. All options are good as such. So then the reflection was what fits me personally the most. And there I think, again, the elements that you explained, that I then also researched myself, I don't like to take long-term medication.
Even though you work in the pharma industry.
Even though I work in the pharma industry, I think long-term medication, anything that you insert into the body, if you have to, you do it. But if you can avoid it, it's good too. As such, I'm very active. I do a lot of sports where I can fall over, where I can trip over, where I can get injured, where I felt blood thinner isn't the perfect mix for that level of activity. And of course, with technology constantly evolving, I had the opportunity through my network to visit the registries of heart valves across Europe. And I saw that unless you get the blood thinning spot on, more or less, in the long term, a technical valve, as good as it is and as well designed as it is, doesn't have that lifelong statistical context as it is advertised, appropriately so. And with the new technology, the valve that we discussed that has a valve-in, valve option, I felt that I'm by far the best looked after. I don't have medication. If statistically after 15 or 20 years the valve were to need any change, that can be done valve-in, valve. And I'm very pleased with that idea. And if I then add that all up, in 20 to 30 years, technology will have evolved so much that I worry about that when I have to. So that's why I thought that this particular valve for my environment and my life setting is a very good choice.
I think that's a very intelligent way of looking at the problem, because it is a problem when you're young and you need a valve replacement, because with you a valve repair was not an option because the valve was already degenerated, had already degenerated. So yeah, it's a discussion physicians need to have with their patients, and I mean that's part of the informed consent, is understanding why we're doing it, how we're doing it, and what the consequences are. And we both are aware that I may never see you again in clinic, or it's possible that in a couple of years you suddenly arrive and your valve doesn't work anymore. However, I do believe with these modern Carpentier-Edwards valves, especially the new Inspiris we used, that durability really is no longer an issue. So we are quite hopeful that it'll last as long as it can. And then what the next steps might be, if it'll be a valve-in valve or some new procedure, we'll deal with it as when we get there. We'll cross that bridge when we get there. Yeah. Okay, perfect. So I'm glad to see you're in good health. Right now you still have a bit of a beta blocker as a medication, and anticoagulation, which we decided to leave for 3 months until the valve is completely endothelialized. So we hopefully will be able to we will discontinue that in 3 months when you go see your cardiologist. Okay, perfect. Do you have any comments or thoughts you'd like to leave with our viewers on the internet?
Questions and thoughts, questions, quick ones that might other patients benefit from as well. If at any occasion I were to forget taking the beta blocker at the right time or the anticoagulant at the right time, is that something which within half a day I can catch up and without any impact of the treatment?
In your personal situation, it doesn't really matter. You can skip a tablet or you can take it in the morning or the evening. For you, it's not that essential because the indication for your anticoagulation is not a hard one. If you were to have a mechanical valve, however, then the timing of your medication intake is very important, in addition to dietary factors. And so if you would have a mechanical valve and take Coumadin, then I would recommend you do self-measuring INR. Now for the beta blocker is a long-lasting beta blocker, so that usually within 20 hours stays in the body. So if you take it 24 hours, once a day, that's fine. And if you miss it in the morning, take it in the evening, it's not a problem. You're taking a homeopathic dosage anyway. It's more for the rhythm stabilizing than for the blood pressure.
Oh, okay. Okay. No, I now have an alarm set, but I thought it's worth checking in advance. And in terms of the rehabilitation protocol as such, we discussed 140 heart rate for now is probably appropriate. Is there any escalation over the next few weeks that we can consider, that I go up to 150, 160?
Yeah, there's a gradual escalation we can do. We'll first do the Holter monitoring. So I'll put him on an event recorder to assess, because Peter had some arrhythmia after surgery, which is quite common, self-limited ventricular tachycardias. So we started him a low-dose beta blocker, which is also a sign that it was more than the best timing for your surgery, because your ventricle is already suffering. So now it has to remodel, and to support the remodeling, we give the beta blockers, low dosage, and we increase the training gradually. So once we have done the Holter monitoring and we can see that these arrhythmias are no longer an issue, then you can start training full.
Very good.
and ramp up the pulse rates.
And there comes then the equivalent to my comment. No, I think I'm delighted how it went. I'm delighted where I am right now.
Mm-hmm.
A month after surgery, I went for albeit a normal walk, but 15 to 20 kilometer walk, hike in the mountains. I can go for runs already at a decent speed of 10 kilometers an hour. I couldn't have asked for
You're
more.
faster than me.
I started much faster too. But I'm delighted. I'm really happy about how it went. And I think it's a blend of obviously the good team around you and colleagues and taking responsibility as a patient that I'm also having to contribute. And I'm really happy where I am.
Okay, it's a team effort.
Yeah.
Well, thank you for your trust. Thank you for coming back to see me again. I wish you all the best.
Thank you.
Take care.
We'll see each other. Thanks.
Bye.
Bye-bye.